malignant disorders. Among that, the most important one is leukoplakia. What is leukoplakia? As the name itself is suggests, leukos means white, plakia means patch. White patch which cannot be scraped off. Okay, so that's a basic that leukoplakia. I'm sorry, leukoplakia is a white patch or a plaque that cannot be scraped off or stripped off. Now, there are many white lesions in the oral cavity, like you have a chemical burn, okay, aspirin burn. There are many other conditions which will mimic like a white lesion, but actually they'll have similar morphology as white lesion, but they can be scraped or they cannot be scraped. Leukoplakia is always non-scrapable. It is always non-scrapable. Now, the thing comes here is that, does all leukoplakia are basically having dysplasia? The question is, do all the leukoplakia have dysplasia? No, it's not like that. All leukoplasias do not have dysplasias. Some leukoplasias will have dysplasia, some will not have dysplasia. Okay, now what is dysplasia? Dysplasia is disturbed or alteration in the cell morphology. So we know that epithelium has got various cells, various layers. So if these layers, if there is some morphological alteration, if there is some cellular alteration, we call that as dysplasia. Like for example, anisonucleosis. What do you mean by that? If two cells have different nuclear size, you call it as anisonucleosis. What is anisocytosis? Variation in cell size. For example, one cell is very large, one cell is very small. You call that as anisocytosis. Poikilokaryosis. What do you mean by poikilokaryosis? The nucleus of a cell is dividing, but the cell cytoplasm is not dividing. That is called as poikilokaryosis. That is why the end result of poikilokaryosis is that it will have a cell with multiple nuclei. Okay, so that is not even the word. And then the very important term in dysplasia is pleomorphism. Pleomorphism. What do you mean by pleomorphism? Pleo means change. Morphism means shape. If cell shape are different, one cell, for example, we'll take one cell as cuboidal, and in the same tissue, if one cell is columnar or squamous, so we are getting two different shapes. That is called as cellular pleomorphism. So cellular pleomorphism is also a very important dysplastic feature. Similarly, we have nuclear pleomorphism. What do you mean by that? Nucleus of two cells are of different shapes. That is called as nuclear pleomorphism. Okay, so those who have joined late, we are discussing today with a very important topic, that is oral potentially malignant disorders. And in this session, today's session, I'm going to give you an overview of leukoplakia. Okay, now in dysplasia, there is a variation in the nucleus to cytoplasmic ratio. What is that variation? Normally, nucleus to cytoplasmic ratio is 1:1. Normal. However, normally it is 1:4. However, in dysplasia, it becomes 1:1. That means the nuclear size is increasing here. Nuclear material is increasing. Chromatin material is increasing in the dysplastic cells. That is why dysplastic cells are more darker. Why are they more darker? Dysplastic cells, why are they more darker? Because more hyperchromatism. More hyperchromatism. This leukoplakia is the most common precancerous lesion. Now this concept has been, that's what, it's obsolete now. We are not going to call this as precancerous lesion. We are going to call it as OPMD, oral potentially malignant disorder. Okay. Now this leukoplakia, this table is very important. I have taken this table from Marks and Stern textbook. This table is very important. What it signifies is that on the left hand side, if you see occurrence of leukoplakia, and right hand side probability of dysplasia. Occurrence of leukoplakia, left hand side, buccal mucosa, mandibular vestibule, maxillary gingiva, mandibular gingiva, tongue, floor of the mouth, lower lip. That means leukoplakia most commonly occurs on buccal mucosa. Most common site. All of you would have seen clinically, when you have seen the patient, usually where do you see that white patch? Usually most of the times it will be buccal mucosa. Rare condition or rare site is your lower lip. Lower lip. But the next side, the table, probability of dysplasia, that is very, very important. Try to understand that. What is this probability of dysplasia? It is telling you the area in which there is high risk of dysplasia. For example, if you see leukoplakia in the floor of the mouth, that means that lesion is going to have more chances of developing dysplasia or seeing dysplasia in that. Okay, so more the dysplasia, more is the risk of malignancy or cancer. So floor of the mouth is one of the very, very, you can say that a very important site. If you see the white patch there, it is a very suspicious. You have to make the patient aware that patient can develop some changes in that area. Similarly, tongue, ventral surface of the tongue is also one more risky area. Okay, that is what probability of dysplasia. So probability of dysplasia is a very important one. You have to understand that in which site there is high risk of developing dysplasia. So among that, the riskiest site is floor of the mouth. Next is your tongue or the ventral surface of the tongue. Okay, this is just general information that leukoplakia can be because of various causes. All of us know leukoplakia can occur because of various causes. One of the cause being tobacco. All of us know that tobacco is in the two forms. One is smoked form, one is smokeless form. Smokeless form means what? Chewable. Like gutka chewing, tobacco chewing. That is called a smokeless form. Smoked means cigarette smoking, beedi smoking. That is one. That is called as tobacco smoke. Now, other than tobacco, are there any other causes? Just in this slide, I just want you to be aware of that there is a carcinogen called as NNN, N-nitroso-nornicotine. This is a very important carcinogen present in the smoke. This carcinogen, which is present in the tobacco smoke, is the reason or the cause for leukoplakia, and further it can develop into cancer. So this is the importance of the carcinogen. You have to remember this nitroso-nornicotine. This is one of the frequently asked MCQ. NNN, nitroso-nornicotine. Okay. There are other causes of leukoplakia other than sometimes tobacco. HPV. This is a very common scenario nowadays. I'll just take few seconds to explain this. Sometimes you might have seen in a clinical setting, in your hospital or in a clinic, patient has come to you. You are seeing a white patch, okay, which is non-scrapable. Then you ask a history. Are you a tobacco smoker? Are you a tobacco chewer? Patients sometimes give you a history that no, I'm not a tobacco chewer, I'm not a tobacco smoker. You should suspect that it could be because of HPV. So now human papilloma virus 16 is considered to be one of the important etiological factor in oral potentially malignant disorders. That is particularly the leukoplakia. There is sometimes another important organism or fungi which is involved called as candida. Sometimes candida can cause a carcinogen called as N-nitrosobenzyl methylamine. N-nitrosobenzyl methylamine. This is the important carcinogen which can even cause leukoplakia or malignancy. There are different types of leukoplakia. Before going to types of leukoplakia, I just want you to understand what are the risk factors for malignant transformation in leukoplakia. What do you mean by that? What do you mean understand by this term? In this slide, I'm telling in this slide what it explains is which are the leukoplakia which are at high risk, which can develop into cancer. One of them is the gender, that is women. Women are at a high risk to develop cancer. If a woman is having leukoplakia and a man is having a leukoplakia, women are at a high risk to develop. Similarly, duration. Longer the duration of leukoplakia, more is the risk to develop the cancer. No habits. If there are two patients, for example, one patient is telling I am having tobacco chewing habit. One patient is telling that I am not having tobacco chewing. Both are having leukoplakia. The patient without any habit is at a high risk to develop cancer compared to with the habit. Location is also very important. As already we have discussed, floor of the mouth, ventral surface of the tongue. If you see leukoplakia, they are at a high risk to develop cancer. Why? Because chances of dysplasia is more there. Type of leukoplakia, you just leave this. I will discuss. Non-homogeneous. What do you mean by non-homogeneous? See, leukoplakia is basically of two types, broadly. Homogeneous, non-homogeneous. What do you mean by homogeneous? It is totally white. A leukoplakia which is totally white is called as homogeneous leukoplakia. It doesn't have any red component. Whereas, if a leukoplakia is having a red component, you call it as non-homogeneous or speckled leukoplakia. Okay, we will discuss that later. So, a non-homogeneous leukoplakia is also at a risk to develop the cancer. Presence of candida, presence of dysplasia, we have already discussed. Presence of candida, because candida can produce a carcinogen. Presence of dysplasia. Dysplasia is again a very important risk factor for developing cancer. Okay, so these are the risk factors for malignant transformation in leukoplakia. Now coming to the very important thing, what are the types of leukoplakia? You can just see here, there are two types of broadly, I have told you, homogeneous, non-homogeneous. What do you mean by homogeneous? Totally a white leukoplakia. It doesn't have any red component. Remember, it has got a very good prognosis. Why it has got very good prognosis? Its malignant transformation rate is only 1%. Its malignant transformation rate is only 1%. That means out of 100 cases of homogeneous leukoplakia, only one case can convert into malignancy, can convert into oral cancer. Whereas 99 cases will remain as homogeneous. Whereas in speckled leukoplakia, that is what non-homogeneous we were discussing, that it will have red component also, white component also. So that speckled leukoplakia is having a bit higher rate of malignant transformation. It is around 3 to 6%. 3 to 6%. So you can understand that if a patient comes to you with a white patch, and if you see carefully clinically, there is a red patch there also, yes, it is a risky case compared to completely white patch. Okay, so speckled leukoplakia has a higher risk. Now, what do you mean by OLEP staging? OLEP staging stands for the oral leukoplakia staging given by Vander Wall. What Vander Wall told is, do two things. Carefully listen to this. Very important concept. A patient comes to you. First thing is, measure the size of the white patch. Whether it is less than 2 centimeter or whether it is 2 to 4 centimeter, or whether it is more than 4 centimeter. The greatest dimension. For example, if a leukoplakia is 3 centimeter, then it will be L2. Because what is L1? Leukoplakia up to 2 centimeter is L1. What is L2? Leukoplakia up to 2 to 4 centimeter. What is L3? Leukoplakia more than 4 centimeter is L3. Now what is P0, P1? P0 means there is no dysplasia. P font stands for pathology. A leukoplakia without dysplasia is called as P0. What is P1? A leukoplakia with dysplasia is called as P1. So if we make a combination of this, L1 P0, that becomes stage 1. L2 P0, that becomes stage 2. L3 P0, that becomes stage 3. Or understand this, in stage 3 you get P1, but L will be maximum L2 only. So stage 3 can be either L3 P0, L1 P1 or L2 P1. Okay. However, stage 4 is highest L and highest P. What is highest L? L3. What is highest P? P1. L3 P. So usually we can get a combination of such like this. How they will ask you is, a 24-year-old male patient with the 4 centimeter size white patch, which histologically shows presence of mild dysplasia. What stage it is? 4 centimeter means L2. Okay. Showing mild dysplasia means P1. L2 P1. L2 P1 will come in which stage? Stage 3. So we should be able to understand this Vander Wall staging. Based on that, we can give which stage, clinical stage of leukoplakia it is. Now, what is sublingual keratosis? You have to understand this term, sublingual keratosis. What is sublingual keratosis is? It is a terminology for the white patch in the floor of the mouth. Obviously, we have discussed that in the floor of the mouth there is high risk for cancer because more chances of dysplasia. Hence, sublingual keratosis is one of the, we can say, riskier site. Okay, now see, this is very important concept. You have to understand the pathogenesis or pathology. A normal epithelium to become dysplasia, to become cancer, following changes takes place. Molecular, these are all molecular levels. What is LOH? Loss of heterozygosity. All of us know there are chromosomes, right? Chromosomes. Now 3p and 9p. What is P is? Short arm. Short arm of chromosome number 3, short arm of chromosome number 9, there will be LOH. If you see LOH there, LOH is loss of heterozygosity. That means broadly you can understand that some chromosomal change takes place there. So if you see LOH in 3p and 9p, there is a high risk that can be a dysplastic lesion, or it can convert into carcinoma. Similarly, overexpression of certain molecules such as EGFR, epidermal growth factor, cyclin D1, MMP9, P53, all these are the one of the molecules. If you see increased expression of these, you should suspect that there is a transition going to take place from normal to dysplasia to carcinoma. Similarly, upregulation of telomerase enzyme. Aneuploidy. What is aneuploidy? Abnormal number of chromosomes. That is also one of the dysplastic molecular change you can see. So all these are at the molecular level, what all can take place in dysplastic lesion. Now this is one of the important image which you should understand, sanguinaria associated keratosis. Now, what is sanguinaria? It's a chemical which is present in herbal mouthwashes. So if an individual is using this herbal mouthwash very frequently, those individuals can develop this white patch in the maxillary vestibule area. Maxillary vestibule area. Okay, this is an image of a homogeneous leukoplakia. You can see here it is homogeneous, completely white patch. There is no red component here. It's a completely white patch. This is another image of homogeneous leukoplakia. You can see here totally white patch. This is a speckled leukoplakia. You can see here on the ventral surface of the tongue where there is a small red area and white patch. Okay, now what is the grading of dysplasia? A very important concept which I want you to understand. What is the grading of dysplasia? Now, dysplasia means, I have told you, disturbed or alteration. If the dysplasia is there only in the lower 1/3 of the epithelium, you call it as grade 1. If the dysplasia is up to middle 1/3, you call it as grade 2. If dysplasia is up to upper 1/3 of the epithelium, you call it as grade 3. If entire thickness epithelium is dysplastic, from lower to upper, complete thickness, you call it as grade 4 dysplasia. So depending upon the cells or the layers which are involved, you can grade dysplasia as mild, moderate, severe. Most severe form is nothing but carcinoma in situ, where the entire thickness of the epithelium is involved. Entire thickness of the epithelium is involved. Okay, that's about the grading of dysplasia. Now this image you can see that these are the dysplastic changes that you can see histologically. You can see all these dark nucleus, that is called as hyperchromatism. Variation in the nuclear size, variation in the cellular size. Okay, that is what is your epithelial dysplasia. Okay, now comes the question, what is vital staining? Vital staining is a very important chairside test. What I'll do is, a patient comes to me, white patches there. Okay, now from which area I need to do a biopsy? There's a total white patch, 4 centimeter for example. From where I have to do a biopsy? That is decided by this vital staining. What I'll do is, I'll take this 1% toluidine blue, I'll just paint it on the buccal mucosa. Okay, whichever area will retain this stain. Now if you wash this stain later, only some area will retain the white stain, the white this toluidine blue. That is the area which is dysplastic. So you need to do a biopsy from that area. That is called as vital staining. So vital staining will tell us that which area we need to do the biopsy. That is your vital staining. Now we'll just finish off this with the treatment part. What is the treatment of leukoplakia? Obviously, the most important goal of treating a leukoplakia is chemoprevention. What do you mean by chemoprevention? We want to prevent the leukoplakia to get converted into cancer. How do we do that? We will do it by mainly vitamin A, that is beta carotene. Vitamin A is a very important chemopreventive agent. This is one of the important MCQ you can expect. Vitamin E is also given, but remember, vitamin E has got only synergistic effect. Only synergistic effect. It alone cannot treat a leukoplakia. It has to be given in combination with the vitamin A. Newer modality of treatment is available, photodynamic therapy. What do you mean by photodynamic therapy? You will give the reactive oxygen, so that reactive oxygen can damage the white patch. Green tea is given sometimes, because one of the component of green tea is an antioxidant, that is EGCG. epigallocatechin gallate, which is an antioxidant, and we know that free radicals are the one of the important um, factor in the leukoplakia or the cancer development. So free radical scavengers are required, that is antioxidants are required. One of the important antioxidant that is given here is EGCG. Similarly, lycopene is also an antioxidant which is present in the tomato. The color of the tomato red color is because of this agent, that is lycopene. Lycopene is also an antioxidant. So this lycopene is also given orally 8 mg per day in cases of leukoplakia. Okay, so this is about the importance of the leukoplakia. Now I'll just give you an overview about one of the important type of leukoplakia, that is called as a PVL, Proliferative Verrucous Leukoplakia. What is this? Try to understand this. This is one of the leukoplakia which typically occurs in women. PVL frequently occurs in women. Patient has come to you, particularly it is a female patient, and you are seeing white patch. Remember, it is not a single white patch, it is a multifocal lesion. What do you mean by multifocal lesion? I'm able to see, I'll show you an image, you'll understand. This is a multifocal lesion. I am able to see white patch on the floor of the mouth, buccal mucosa, tongue, lateral border of the tongue, dorsal surface, ventral surface. So many areas I am able to see the white patch. This is a multifocal lesion. In a female patient, multifocal lesion is there and there is no identifiable cause. What do you mean by no identifiable cause? Patient is not giving any history of tobacco. Then what is the cause? HPV. As already discussed, if tobacco is not there, think of HPV. So in PVL, proliferative verrucous leukoplakia, HPV 16, HPV 18 are the two important organisms in the causation. Evolution of lesion. What do you mean by evolution of lesion? The lesion won't remain static. It will evolve. It will spread. It will enlarge. That is a specialty of PVL. So this is a clinical setting. That means patient has come to you. It's a female patient. Okay. There is no identifiable cause. You are able to see multiple white patches. And patient is telling that initially the white patches were small. It has evolved over a period of years, months to years. Then you come to a conclusion that this is a PVL, proliferative verrucous leukoplakia. Why are we discussing this lesion so much? Because it has got a highest malignant transformation rate. Malignant transformation rate is almost up to 70%. It's almost up to 70%. Okay. High recurrence. What do you mean by high recurrence? So if I will remove that white patch, PVL, there is a high chance that the PVL can recur again. That is the importance, that there is a highest malignant transformation rate, highest recurrence. We have to understand this PVL. Now this PVL basically has two important criteria. I'll just, in this session, today's session, I'll just discuss only about leukoplakia, and that's why I'm discussing about PVL. We have got a very important criteria here called as a Serero-Lepedra criteria. So this is an important criteria about the diagnosis of PVL. What Serero-Lepedra told is that there are 5 major criteria, 4 minor criteria. Okay, what are those criterias? Okay, we need not go at this level for the at the NEET level or PG entrance exam level. It's at the postgraduate level we have to understand. here we are supposed to understand the name of the criteria, that is Cererolepidra. What he told is that if I have to call a patient as PVL, I should see either 3 major criteria or 2 major, 2 minor. Combination. Totally there are 9 criteria, 5 major, 4 minor. In one patient, if you see 3 major, then also it is PVL patient. In one patient, if I see 2 major and 2 minor, then also it is a PVL patient. One major criteria which is always seen in a PVL is histology. Biopsy you have to do in case of PVL. Okay, you have to do, it's a mandatory in case of PVL. To modify this Cererolepidra, Gerard has given this criteria. So he has summarized entire thing. He has summarized. What he told is, if you see white patch in more than 2 areas, that's what I have told you, multifocal. If I am able to see white patch on the buccal mucosa, if I am able to see white patch on the floor of the mouth, that is what is the multifocal lesion. Minimum size at least should be 3 centimeter. If I club all the white patches, at least size should be 3 centimeter. It can be 5, 8 centimeter, but minimum white patch entire clubbing is 3 centimeter. Evolution, as I have discussed, patient should give you a history of at least 5 years. That means patient will say that these white patches, for example, 2024, a patient comes to you, patient will tell you that since 2018-19, this patient is having these white patches and they have increased in size. They have recurred, they have enlarged. That is called as evolution. So evolution period is very important. That is at least 5 years. That is what is a Gerard's modification of the PVL. So PVL is a very important condition, potentially malignant disorder. Why it is so important about the malignant transformation rate, about the recurrence rate. It is highly malignant. Chances are there 70%. That means if 100 patients of PVL are there, 70 have got a high risk to get converted into cancer. Okay, and it is highly recurrent. That is the importance, clinical importance of the PVL. And PVL is also again a very hot topic for the MCQs in the exams. Okay, so that is about the leukoplakia and the erythroplakia, PVL, proliferative verrucous leukoplakia, and about the overview of the what do you understand by precancerous lesion, what do you understand by precancerous condition, what do you understand by oral potentially malignant disorders. So now we are not going, WHO has removed this term precancerous lesion, precancerous condition. WHO has clubbed and it has given a common term, oral potentially malignant disorders, OPMD. Okay, that is the terminology that we have to understand. And leukoplakia and PVL are the one of the important OPMDs, that is oral potentially malignant disorders. Okay, I hope this session would have given you an overview about the leukoplakia, and in the next sessions, definitely we'll have next sessions on the YouTube. That is DAMS MDS Quest, the channel DAMS MDS Quest, where we'll have many such sessions where we will be discussing what are the other potentially malignant disorders. Like one of the important one is oral submucous fibrosis. All those topics we will be discussing in the next coming sessions. Okay, thank you very much. I hope this session would have helped you. Anything you have any doubts, you can, after watching this video also, you can please pin the comment. You can comment, just put a comment there on the video. I'll be able to solve any of your doubts. Okay, thank you very much.